Dear Facebook Pure Urology viewers, good evening one and all. Today we are discussing about the learning curve of the RIRS. As you all know, retrograde intrarenal surgery is developing last 10 years very much, and all the juniors are willing to learn retrograde intrarenal surgery and to practice outside. The only problem is the equipment is costly. Not all centers are doing it, so they may not have exposure during the training period. Once they go outside, they may not know where to get training, and directly starting may lead to loss of the scope, loss of the equipment, laser fibers and all. To discuss this, the person who has experience, who has learnt RIRS not during MCH and then learned RIRS afterwards, and now in the position to train the juniors over a period of 3 years, Dr. Rakesh Panda, who is consultant Preeti Urology and Kidney Hospital, will speak today on this topic, because he has learned from the zero and now he is able to do all the cases in RIRS. How the transformation has happened, let us listen from him. Before we go to the talk, I will briefly introduce Dr. Rakesh Panda. Hello, Dr. Rakesh.
Hi, sir.
Yeah, thank you. Thank you for being with us, both as consultant as well as today for Pure Talk. Rakesh, where is your MBBS?
Sir, MBBS I did from MKCC Medical College, Berhampur, Odisha, sir.
Okay. And where is your MS?
MS surgery also I did there only, MKCC Medical College, Berhampur, sir.
And MCH?
MCH I did from SCB Medical College, Cuttack, sir, Odisha.
Who is your mentor in urology?
Datteshwar Hotta sir was my mentor, sir. He was HOD and mentor in my training period.
During your training period, was PCNL there and RIRS was there?
RIRS we have never seen, sir. It was not there, but we had laser machine, sir. And PCNL, I have never done PCNL before, but I have seen assisted cases, a few cases.
Okay. So, how many urology seats were there during your MCH with your colleagues?
4 urology seats were there.
4 urology. So every year 4 into 3, total 12 urologists were there?
Yes, sir. All urologists were there, sir.
Okay. So now let us listen from you, and we will see your curriculum vitae. Same thing I will read. So dear friends, today our talk is learning curve of RIRS. Dr. Rakesh Panda. He is MBBS MS MKCG Medical College Hospital, Odisha, MCH from the SCB Medical College Hospital, Odisha, Fellowship in Endourology and Laparoscopy at Preeti Hospital under Dr. Mentorship of Chandramohan, Consultant Urologist, Preeti Urology and Kidney Hospital, presently at Hyderabad. Got Best Video Award East Zone USICA in 2018. One of the faculty member for VLD Endourology Fellowship Program conducted at Preeti Hospital. Published original articles in reputed journals. So with this introduction, I will hand over the program. Dr. Rakesh, please concentrate and speak crisply. What are the difficulties you had RIRS? How many days it took and how many months it took? When you became confident? What is the message you wanted to give to the juniors when they wanted to become RIRS surgeon? Thank you. Over to you.
Thank you, sir, for your kind introduction. Respected seniors, my colleagues and my juniors, first of all, I would like to thank my mentor, Dr. Chandramohan sir, for giving me this opportunity to talk on this topic. And let me share my screen. Am I visible, sir?
Yes. You can proceed.
Okay, sir. Today we are going to talk about learning curve of RIRS. Even though I am not enough experience to talk about this topic, as I have worked in this hospital for 3 years, today I will share my experience.
Yes.
So we'll discuss this topic under 5 subdivisions. Which training center you should join, how many months of training is required, which scopes are used to learn this RIRS, and how much you have to pay for learning it, how many cases you have to do before going for private practice. So coming to the first, which training center to join? In India, a lot of surgeons are doing RIRS, but official fellowship programs are not there. So when during MCH time, I had no exposure to RIRS, but I was very keen to learn it. So I joined in Preeti Urology and Kidney Center, where daily 3 to 4 cases of RIRS is done. Next, the learning RIRS is a step-by-step process. My first step was observation. When I joined in fellowship here, during the first month, we observed what are the scopes used, what are the instruments used, the scope movements, what is irrigation fluid logistics, and what are the laser settings used, how to insert the laser fiber, all these. So this is, and one more important observation was how to arrange the trolley. This is how you should arrange the instruments in trolley. There should be adequate gap between the instruments. As you can see here, this is the flexible scope, this is the semi-rigid ureteroscope, then access sheath, 0.018 guide wire, and extension tube with 50 ml series used for irrigation. Then after connecting the camera head, this pointer should come at 12 o'clock. So this is used to orient ourselves to the internal anatomy. Now coming to the scope movements, there are basically 5 scope movements. As you can see here in this video, the first scope movement is front and back movement. This movement we use when we go inside the kidney. Then this is flexion and extension movement. Only flexion movement only we use when we are going to inferior calyx. Then this is external rotation of scope. When we are doing any right side renal surgery or the stone is at 9 o'clock position, we externally the stone is at the 3 o'clock. Stone is in lower anterior calyx. We just the scope against the calyx. And this is another movement, file movement. We just rotate the month. My next step was assisting in flushing the irrigation fluid. What is the importance of this step? As you can see in this video, you can hardly see the movement of the water column here. The flushing is very gentle and slow, so that there won't be any rise in internal pressure. Stone fragments should not move to difficult calyces, and clots should not be formed inside the kidney. As well as at the same time, you should maintain proper vision to the operating surgeon. It's like playing double tennis. You should go hand in hand with your partner. Then one more important observation was the fluid output from the access sheath. The fluid coming out from the access sheath is like this, then there is less rise in internal pressure, and there won't be much complications after RIRS. Then third step of my learning was ureteric access sheath placement. During my second month of fellowship, I was given this opportunity, and before placing the access sheath, we do usually initial ureteroscopy with 6-7.5 scope like this. With this scope, we go up to upper ureter. What is the advantage of this step? With this step, we can know whether the ureter is accommodable or tight. If we can go like this up to ureter freely, upper ureter, then the ureter is accommodable. We can do the RIRS easily that day. Suppose there is any restricted movement or ureter is gripping the scope, then we shouldn't attempt RIRS. We should stent it and come back after 2 weeks. We use these access sheaths, more commonly 9.5 by 11.5 from Cook access sheath. This comes in 2 sizes, 28 centimeter and 35 centimeter. We place this access sheath under CM guidance, like this. So first we put a thick guide wire, 0.032 inch guide wire over with ureteroscope. Then slowly over it we load the access sheath and gently push under CM guidance. Always follow the course of the CM access sheath under CM guidance. It should be gentle and slow. In this method, there is chances that the access sheath may get buckled, especially in case of high blood neck. We should be very careful. Then after placing access sheath, I was given the to do mock RIRS, which we call for the next 2 weeks. That is after each case of stent removal, we'd go inside the kidney with flexiscope and we'll do gentle RGP and try to reach the calyces. This is always done under the guidance of a mentor, and we'll try to reach all the calyces. We'll try the all scope movements. This increase my confidence level. So whenever when I started doing RIRS, there was always problem while holding the flexible ureteroscope. We always used to hold by lifting our shoulder up, and by the elbow will be little away from the body. This is not the right way to hold. But after doing right repeatedly and guidance from mentor, we could hold the flexible ureteroscope like this after a few days of time. Then the last step of my learning was choosing the right case. So initially, we are told to do simple cases like any single stone in the superior calyx. As you can see here, this is a single superior calyceal stone of size 1 centimeter. You will go inside the kidney. The stone will be right in front of you, and you can finish the case easily. So I started my cases like this. Then gradually, and initially we did these cases under general anesthesia. This is recently one case I have done under spinal anesthesia. You can see how much the kidney is moving. I was struggling to focus uh, to touch the stone with laser fiber. So initially, to do with general anesthesia, that is better. We can control the respiration. We can reduce the respiratory rate and tidal volume, so that easily we can do it. Then this is one more example of ideal cases to start with. Single middle calyceal stone. Whenever you will go inside the kidney, the stone will be right in front of you, and you can finish it. Then always single upper ureteric obstructive stones are also ideal to start with. You can always go inside and push the stone up and do the case. But I would recommend in these cases to stent it, because there are two advantages of stenting in these cases. First, the obstructed system will be decompressed, and second, the ureter will be dilated, so that we can come back after 2 weeks and do the case easily. Initial period of career, we had very low threshold for degestenting. Whenever the ureter was tight, we were least resistant to put a degestant. Then how many months of training were required? Fortunately, in the third month of my fellowship, I could start doing RIRS. I started with simple cases like this. I told single middle calyceal stones. Now also, after me, 10 fellows have passed out from this institute, and all are doing RIRS now easily. Now also fellows are able to do the cases during the third months of fellowship. So after gradual training during fourth and fifth month of fellowship, I started doing these inferior calyceal stones. We always basket it to a favorable calyx, then do the RIRS there. Then which scope to use first when you are choosing? This is my opinion according to my experience in 3 years. I have used both the fiber optic scopes P7 and FlexX2. P7 has better vision, and we are using it for last 2 years. Not a single scope has been damaged during my fellowship period, and P7 easily comes for 100 cases. I have seen it. Then coming to disposable scope, we have used Biorad and Indovasive. The problem is it needs larger access sheath, 10 by 12 French access sheath. So prior stenting cases are better. The ureter will be dilated, and you can put the larger access sheath. So initial ureteroscopy with 7.5 French URS is a must in these cases. Coming to the laser settings, initially when I started doing RIRS, it was always confusing to remember the laser settings. I was always confused to remember. To some stones we are using like 1 joule 10 hertz, some 1 joule 8 hertz. But after doing cases for a significant period of time, I could remember the standard setting. As you can see in this video, we are using 1 joule 10 hertz and dusting the stone. Always it's better to dust the stone from periphery to the center and continue dusting till the end. The results will be better and SFR will be good. So when I started doing cases, I started with laser setting 1 joule and 8 hertz. and it was taking to dust completely 30 to 40 minutes for a 1 centimeter stone. So coming to thulium fiber laser has a lot of combinations, settings like dusting and popcorn mode, fragmentation popcorn mode. We were using zero point 0.1 and 60 hertz in dusting mode. Then now recently we are using fragmentation mode 1 joule and 10 hertz, and popcorn 0.1 and 10 hertz. So the main point is the end result is fine dust should come like this. Whether you do dusting or popcorn or fragmentation of popcorn, always the two things are very important. First is you should use the low power should be low in the initial period of time, less than 10 watts, and always dust till the end. Which laser is better? Coming to homium versus thulium fiber laser, I am not enough experience to make a comment on this. But according to my experience, dusting is always better with homium laser. Like if someone is like Chandramohan sir likes to do complete painting of the stone, it's always better with homium laser. Thulium fiber laser is better for large stones, more than 1.5 centimeter to 2 centimeter stones. The high frequency of TFL helps in popcorn and easier stone disintegration. Now, recently we have done a 1 centimeter stone with TFL. It only took 10 minutes. So with experience, you can use more. TFL is better for larger stones. Then coming to how much you have to pay for learning RIRS. In some centers, I won't like to name. They take money for to teach for fellowship programs. But here, no payment registration is required for BLD and urology fellowship, and we are paid 50,000 stipend per month. And you can join anywhere there is enough exposure to RIRS, and you can learn it from mentors. Even observers for 3 months is enough. You can learn the whatever I told, like all the scope movements, how the trolley is arranged, all these things you can observe, and you can go back and you can practice on your own. So how many cases you have to do before going to private practice? As I told initially, after 50 cases of observation, I did access placement for next 15 cases, then slowly only mock RIRS for 5 cases, then started with simple cases. Then after doing around 40 to 50 cases of simple RIRS, we can go ahead with advanced cases. By advanced cases, I mean to say ki more than 1.5 centimeter stone or multiple calyceal stone. There are multiple stones in multiple calyces. You can go ahead with these stones. And whenever you are going for any fellowship program, after completing fellowship, always try to continue doing cases. If you stop after going, then there is no value of doing this fellowship. Now coming to this video, this is the video showing how I was doing RIRS in the left side of my screen during my 3rd month of fellowship. You can see, and this is the right side of screen now how I am doing now. This is a case recently done. You can see almost during the 3rd month of fellowship, I could do RIRS. This all credit goes to my mentor, Dr. Chandramohan sir and Ramakrishna sir, for guiding me and helping me. So this is a study done by AUA University during regarding the learning curve of RIRS. They have also concluded at least 60 cases required to achieve the plateau of learning curve of RIRS. So to conclude, good mentor in a high volume training center like Preeti Urology Kidney Hospital made my job easy, and I could learn it very faster in 3 months of time. And you can always start with simple cases like single middle calyceal or pelvic stones and supracalyceal stones. Handling of scope and ureter is very important. You should take care of ureter. Ureteral dilatation is very important. Initial ureteroscopy with 7.5 scope before proceeding with access placement is very important. After 50 cases, you can try for advanced cases. Thank you.
Rakesh, am I audible?
Yes, sir.
Thank you for crisp presentation. It is not the question of which center and how. Mainly, you have made it clear that you have to spend minimum 30-40 cases under observation. After that, you can go for initiation of the access sheath. Entire world training is divided into subparts. Now, varus needle insertion, port insertion, colonic dissection, then duodenum dissection. For all these, you need high volume center.
Yes.
So you have nicely told what are all the things, but you mentioned that I feel it is wrong. You mentioned that many centers are charging. Do you think that for brief period, if you charge some amount of money, is it wrong or is it correct? As a junior, as a junior MCH urology passed out, what was your feeling? As 3 years post MCH consultant, how do you feel now? And in future, if you given everything by God, will you like to do free of cost training of the juniors, or nominal charges is okay?
Nominal charges is okay, sir. They are doing, it's okay, no problem, sir.
So nominal charges is okay. See, some people say there should not be free anything. Just because one person is doing free, everybody need not be doing. There are certain very good paid services. For example, if you see in Western countries, nothing is free and they are paid services. So as of now, we have kept it is free of cost because it is 6 months. We are also getting benefit in fellowship because they will see the patients, they will write the notes, they will see the post-operative patients, they will see the sick patient, they will see the rounds on Sunday. It is always give and take win-win situation for the fellow as well as the mentor. They can write papers, as all of you have written papers, and it helps. So any fellowship program, even if it is paid, you see your affordability. What seniors when I went to join Dr. Mallikarjun sir 17 years back to him, that time there was no post with him. Then he said that go and 3 months you do fellowship and then come back. 3 months each subject, world famous persons you go and fix. Most of us does not have money. I did not have money at that time to go for the fellowship as suggested by sir. Actually, I went to sir for any job, but he suggested there is no job, you go for every 3 months fellowship. So now in India, lot of surgeons are willing to teach, Rakesh.
Yes.
See, for example, Dr. Tanuj Paul Bhatia is there, who is already doing. Dr. Harshavardhan has already started.
Yes, sir.
Dr. Anil Shrestha is conducting in Nepal. Dr. Anil Varshney sir is doing occasionally.
Yes, sir.
And Nadiad, lot of conferences happen, as you all know. I learnt many times going to Nadiad. So all the juniors should be continuously aware and continuously ask different seniors. For example, every person may not be experienced in everything. Yes. There are few institutions which does everything, but many people may not do all the things. So first 1 or 2 years of your post MCH MS, especially during Corona period, lot of the juniors did not get much opportunity to operate.
Yes, sir.
Dr. Kulakarni sir is also offering fellowship as well as the training program. Nadia is offering. I think in future, lot of people will be interested in teaching. Main reason being, they can expose their work, they can show their best work, they can do better with the juniors, they can get their work done by the juniors in terms of paper writing, and over a period of teamwork also can form. For example, my consultants are my fellows only once upon a time. So like-mindedness will increase the job. So all the juniors must be given opportunity.
Yes.
Now second question, this is the answer I want to give because fellowship can be little bit chargeable, free also, stipend also can be given. Even Dr. George P. sir is doing excellent program, fellowship program. It is a very famous program in India.
Yes, sir.
Workshops are different from the fellowship program or observation program. For observer program, the problem is if too many people are there in the theater, infection may occur. Operation theater is like temple. We cannot allow everyone for the observation. So we slightly discourage observership. But there is nothing wrong in one observer, one fellow. At least observer will not feel disappointed. He will work for 9 to 5. Maybe he will not be paid as much as fellow and he may not be answerable. But he will learn. he will learn and go. This should be the motive in exchanging the knowledge.
Yes, sir.
My second question, do you think that by assisting the case by wearing the gloves, see, lot of people will watch from outside. Does it make any difference? For example, if you go for any lab case, long case, observing from outside and wearing the gloves and assisting, does it make any difference, Rakesh?
Yes, sir. It makes a huge difference. Whenever you wash and go for the case, you will feel the pressure. You will feel the stress inside, and you will be more attentive.
Yes.
You observe all the things, what's going on, how is cutting. Same step, if you are observing outside, you may not notice like that. If you are cutting a ureter and like if you are inserting the laser fiber, if you are there in the case, then you will observe more, you can observe it more.
Yeah, I
Properly.
strongly feel you are correct, because if you are there outside, you will be going out and in. Sometimes you will miss the basic points. If you are continuously inside the OT, also your concentration may lapse. But when you are wearing the gloves and assisting, you, as you said, it creates stress. You have to assist the senior very well. You have to follow each step very well. You have to continuously flush the water.
Yes,
Everything is important.
more attentive.
More attentive. Now, second question I want to ask: whenever you are alone, now you are running one of our hospital independently. Whenever you are alone, do you like to use small access sheath out of fear, or larger access sheath is okay? How many, as the time goes on, your confidence to put larger access sheath is increasing in learning curve, or you still benefit of doubt you wanted to go for a smaller access sheath? What is your opinion?
So normally we go with the smaller access sheath only.
Okay.
That is my first preference, sir. But if I am using any disposable scope, then only I am going with this larger access sheath, or especially in post-tented cases only I am trying it, or else I am not using, sir, this.
So you are correct, and in not post-tented cases, you try to prefer 9.5 by 11.5 access sheath with P7 scope.
Yes,
That
sir.
is the reason why our units are not doing disposable yet, even though it is very logical. I am not saying. My third question, if you wanted to do a large stone, if you see in the OPD, if you in the large stone like 2 centimeter, at this stage, do you like to stent and be happily doing, or you will try half of the stone without stenting? What will be in your mind?
Sir, if I see a large stone and planning for RIRS, then first I will go do the initial ureteroscopy. If the ureter is normal and the fluid output from the access sheath is okay, it's coming freely, then I'll use thulium fiber laser and I'll try to complete the case. No problem, sir. Primarily, I will do RIRS.
Okay. If you feel that the ureter is tight and just it will take time, what will you do?
I'll definitely put a stent and come back after 2 weeks. Sir.
So for the audience, for the juniors, my message is little different. I like to put stent and then do. Even if you do free of cost stenting, do it. 90% of the complications will not be there if you put a stent and go later on after 10 days. Nobody will curse you, and if infective complications is less. I mean, of course, one time ureteroscopy under GA versus stenting under local anesthesia, more than 2 centimeter. I like to put stent, large stent, 5 French, and then go after 2 weeks inside. See, that fear of damaging the ureter, that fear of sepsis, that fear of fluid coming out will not be there if the stented. Why in conferences? Yesterday we were doing an Ahmedabad conference. Even after stenting, Dr. Kandarpar sir told that ureter is tight. I will not do. See, that is the senior experience. If you do, he knows that the post-op patient will have problem. Whereas my case, post-stented wide ureter was there. I was very confident. All the powder I was washing, and ultimately it helped me. So all the conference cases are stented means better benefit of doubt. Your patient should be like conference patient, and you put stent and do it for first 1 year, 2 years. After that, now you are third year, so okay, your answer is okay. Now my fifth question, Rakesh.
Yes.
After how many cases of watching, see, now the students are expecting within 1 week give the scope. Do you think within 1 week they will be able to handle the scope without previously not at all seeing? However intelligent they are, how can we give cases to a patient, our own private patient? What should be the observation period? Again, I am asking your experience. Now, will you give first five cases, afterwards only flexible scope? What are the problems you see with them? Tell me.
The observation period should be minimum of 2 weeks. They should know what are the instruments used, what are the scope movements, where the surgeon is facing the see. Suppose I am doing the case, I will do it easily. I can negotiate the ureter. But suppose some fellow is doing, then he will face the difficulty in the curves of the ureter. So first you should observe where is the what are the scope movements, how he is doing external rotation, where he is doing internal rotation, and especially tight ureter, he should know which ureter is tight, which should be stented. This should come with a period of time. Minimum of 2 weeks of observation is a must, sir.
So, for example, your son tomorrow wants to do fellowship very fast. Do you think that in 10 days can you train, or he also has to undergo minimum 2 to 3 months?
Minimum, sir. Minimum 2-3 months is must for all.
That too in a center where daily 4 RIRS are done.
Yes, sir. High volume center.
In fact, learning curve for when compared to RIRS, PCL and laparoscopy is still more, I feel. What is your opinion?
Yes, sir. It's more, sir.
That means you have to work more period of time in PCL and
laparoscopy.
Some people may be gifted in their training period. They may have the puncture, they may have a good boss. Yes. Then there is no need. Yes. For example, a DNB student who has learnt from day one high running center, then they can go and practice, no problem. But all the centers may not have like this. Yes. So now better to spend 6 months to 1 year during the fellowship where all the, or else go to fellowship 3 months in different places, request, and then be observer or be a fellow or be a consultant. There is no problem. Now, yes. My next question: when you are not getting outflow of the water, do you think you can give to fellow and do it with forcibly water if a small stone is there, or will you take over and see any difficulties there? How do you encourage the fellow? Because in a difficult case, do you give the surgery to the fellow and ask him to do continuously, or you will take it immediately and then explain him where it is going? How do you address a fellow not able to do the surgery in the beginning? How do you address?
Sir, if there is a less fluid output from the access sheath, I won't give it to the fellow. You should finish the case as soon as possible.
Yeah.
Or else patient will get post-op fever and post-op lung pain. These two conditions are very important. So I will take the case and I will complete the case as soon as possible.
Yes. And how do you encourage the fellow when he may feel bad that you have taken, and learning curve may go down and the steep learning curve may happen? How do you address him during training?
Sir, first of all, during observation, we see all the cases the fluid coming out from the output from the access sheath.
Very good.
So he will observe. If the case the fluid output is less, then he will know that I shouldn't do, and I will explain him that this is not the right case you to do, and you can do it anytime. We are doing lots of cases. You can do the next case. Then I will complete the case. Patient safety is important first.
Yeah. So that's why. Do you think any center, when a fellow of new person, see, I have seen some of the fellows who have left after 2 months. See, saying that we are not given complete cases. So, do you think PCNL, those who doesn't have experience in private practice, can we give the cases to fellows from the day one, and without mentor, can we sit outside, and then after injury, if you go, is it correct or not? And what is your experience? Because 10 fellows you have observed. What is in your mind? How will you train if I give a fellow? How will you train?
But learning PCNL is also like same stepwise process. We shouldn't give them from the day one. First, we should give them puncture. The main important step of PCNL is puncture. So there should be the puncture is a 3-dimensional step. You have to have some idea about the anatomy of the kidney. Once they master the puncture, then we will give them dilatation, then go inside the kidney, then lithotripsy. So this requires a long period of time. Puncture itself is a very complicated process, sir.
Yeah. So do you think that training period DNB MCH, if they have a lot of cases done, it has advantage, or if it is not trained properly, still they may not do well. What is your opinion of MCH DNB training?
Definitely, sir. It's advantage if you are exposed very much, like we did open cases in MCS training, so that we can do. We don't have any fear in open cases, open nephrectomy or open pyeloplasty. Like that.
Yeah, yeah.
Same thing. If they have done PCNL and RIRS during their MCS training period, then they can do it easily in private practice.
So that advantage and edge will be there.
Yes, sir.
Yeah. So if you do fellowship and after going outside, do you think that a gap of 6 months without doing anything may decrease your skill and you may again get little bit of confusion, or should we go directly to private practice once you think that you have done adequate fellowship? What is your opinion?
No, sir. There should not be any gap. Whenever you complete the fellowship, you should keep doing. Practice makes the man perfect. You should keep doing the cases. At least once in a week, you should do RIRS, or else you will forget. After 6 months, you will forget all the laser settings. What is the laser settings used? How the scope, the movements also you will forget. Everything you will forget.
Yeah. So in the initial period, forgettability, I also agree with you.
Yes.
After you become senior, you may not forget.
Yes, sir.
But one more thing, eighth question. The laser settings, we always, even now, TFL laser settings, sometimes I ask Dr. Soundar and Hemnath or Manas for the enucleation. This type of laser settings, repeatedly we forget. We go to conference, we listen, and repeatedly we will forget.
Yes.
What do you think, like now you are also training and you are also now have your laser settings with you. How you memorize? Is it only by seeing and adjusting, or outside like a technician you also adjust? What is in your mind?
Sir, initially when I started doing cases, when I joined fellowship, I used to forget everything. Then I used to ask OT brother, what is the setting, you tell me. Then I used to ask the seniors. Then after doing number of cases gradually over a period of 6 months, the standard setting, it memorized in my brain. Then now it's coming off its own. No need to remember.
Yeah. So it is not easy in the beginning, especially thulium fiber laser. So many variables are there:
Yes, sir.
testing, popcorn, fragmentation, right button, left button. So do you think that we used to write on the paper and stick? Do you think that those things will help? And senior technician always helps.
Yes, sir.
Because they will assist many times. So do you think that technician should not be changed and they should be kept in learning period?
Yes,
Do you think in private practice it is very important?
Yes, sir, very important. In fact, in our OT, our OT brother Sridhar has assisted me a lot, encouraged me a lot in all these OT laser settings. While PCNL also, whenever you are doing a case, you will get demoralized if you don't do a puncture. You can't do a puncture. Then they will assist, they will help, and they will give moral to you. And these things like whenever you doing something wrong in the steps, also you are inserting laser fiber wrongly, and you are puncturing the mucosa. They will guide you. They help. They have the experience.
Yeah.
They will help definitely.
So you should develop manpower and you should develop the OT technician. You should also develop your humanity with them, and they will help a lot. And always bosses will be angry and they will be busy. They may not explain completely. So you should take help of the OT technician and then come out.
Yes.
Now last couple of questions. For all the juniors who doesn't have exposure to RIRS, what is the message you wanted to give?
The first message is like I also had no exposure to RIRS in my MCS training. Then I met Chandramohan sir in a conference in Agra. Then I saw his surgery. He was doing RIRS in that live conference. Then I got influenced and I thought I should join him. Then I requested, sir, I'll join. So in my experience in these 3 years, I would like to recommend all should join in a high volume center, and a good mentor is a must. If you join a good mentor and high volume center, learning is easier and faster. Like if you start on your own, you go to workshops and you watch the surgeries. If you start on your own, it will take long time to learn. It may take years, 1 year, 2 year, like that. And there are chances of early scope damage, which will demoralize you. So it's always better to join a fellowship program or any observership program, and then start gradually go to workshops, then practice on simulators, then gradually do mock RIRS, like go and do flexiscopy after stent removal, then come with simple cases. This should be like a stepwise process.
Very good. So I really appreciate the message. And Do you think that low socioeconomic condition of our MCH DNB residents after passing, do you think that still it is worth living in a small place with less expenditure, without spouse, without children? 6 months to 1 year spending with people is difficult. Do you think that it is still worth? You all have faced that. Instead of spending hard time in the private practice for 5 years, it is better to spend 6 months somewhere in a fellowship and try to go any fellowship. Anybody, is it better? How do you think? What do you think?
It is 100% better, sir. When we joined fellowship here, we used to work from 9 to 9, but that 6 months were like crucial.
Yeah.
3 months only I could learn RIRS. That itself was like more than it was worthy.
Yeah.
So there is no doubt about it, sir. It's worthy to go and do the fellowship.
Yeah. So see, to conclude, Rakesh, thank you very much for being with us. You have learnt and you did not have exposure, but you continuously persevered and you have learnt. So the message I want to give to all the juniors is: first thing is you see what area of interest. Second thing is, don't directly go to super specialty. Wait for 1 or 2 years. Do all the things: URSL, PCNL, laparoscopy, transplant, fistulae, AV fistulae, urethroplasty. You should have exposure. If in your DNB or MCH program you have exposure to all, you are very lucky person. Fine, no problem. If you don't have exposure, try to identify people. Go and ask. There is nothing wrong in asking. If they say no, no problem. If you go and ask all the people, some will say yes, some will charge for it, no problem. Borrow somebody, worthiness you see. Some will say only 1 month you observe, even then you go. Stay in a small room nearer to hospital, day and night you work, because anyway surgical career is long a career. You have already sacrificed the life so much. 1 year, if you go to 2-3 places and learn, I am telling you, all the fellows who have done with us, they are going outside and doing well. Similarly, consultants are also extraordinarily flourishing outside. Apart from attending the live conferences, you also, because every day you cannot go for live conference, spending lot of money in hotels, lot of registration fees. Instead of that, in either places like Hyderabad, people are staying in 10,000 room. Not only the rich children also, because of attitude, they are staying nearby. They are 10,000 rupees food they are getting, 20,000 is over. So you can somehow continue. Work is the worship, divinity, and then learn and go to the private practice. Definitely you can do justice to your patient. That was the aim of the today's talk, and Dr. Rakesh has justified his gestures. Some of the people like Arshavardhan has watched and said that thank you and nice talk. So in future, let us see how the training will go, because number of patients are decreasing, number of surgeons are increasing,
Yes.
availability of new facilities are increasing. Learning is a constant process. For me, honest, Nadiad MPH, I used to go every 3 months when I did not have money, and that helped me to learn in 2006, 7, 8. After that also I like to go and learn. So learning is a constant process, worth spending money on that and worth spending some time on that.
Yes.
So thank you very much, Rakesh. With this we
Thank you, sir.
conclude the session.